We're winding down, still a lot to cover, and maybe some interesting things. Hopefully interesting things. So I think all of you in your folders or in your white binders, whichever one you have an instrument called the Duke Health Profile. So we're going to work on that. And then behind that, you have the Pediatric Symptom Checklist 17, or the PSC 17. So I think what I'll do to give you all an idea of how useful these tools are in all visits with patients. Well, the Duke is all patients age 18 or over. I think I'll just do a quick role play, and then I'll show you on my computer how to score this and how quick it is to score it, and the scores that you get, because all of the behavioral health consultants have this scoring program that I will use on their thumb drives. So it's very easy to score and very useful. So just getting ready to do that, let me explain why we recommend you're using the Duke Health Profile as your primary outcome measure with the patients you're going to be seeing that are 18 and over. It is, first of all, normed on primary care patients. Second, it's very brief. It takes about 3 minutes. Patients can complete the form by themselves, or you can ask them the questions depending upon their health literacy. The Duke is available in about 28 different languages, so you're not going to run into much that it's not available in. And what the Duke offers is a measure of health-related quality of life. Now, is there a single primary care patient that we don't care about their health-related quality of life? Probably not. I mean, we could almost use this as part of the visit check-in. But certainly for a visit with a behavioral health consultant, it makes a lot of sense. So 17 items, and it gives you a variety of scores. The scores that I recommend that you integrate into your electronic health records are a physical health score, mental health score, social health score, and the general health score. That's the summary score. These scores all range from 0 to 100. It's like your spelling test. 100 is better. So very intuitive and very useful in terms of looking at the patient clinically. Are they improving? In terms of your team members being able to know, where is this patient functioning, what's the pattern over time, and very useful in aggregate reports. So you can, if you get it integrated into your electronic health record, you can query your system and you can say for patients who with a BMI over 30 that see a behavioral health consultant more than twice, is there a change in their physical health score on the Duke? A meaningful question, very meaningful use. So unlike the BHQ-9, which is a wonderful thing in and of itself, this is a measure that applies to all patients, not just depressed patients. And consistent with the primary care behavioral health model, it's more of a strength-based kind of instrument. So it's easier to talk with patients without creating more depression. You don't have to say, oh, your number's so high. You have so many symptoms. Instead, you can say, wow, looks like relative strength is social health today. We'll see if we can't build on that and address some of these other things. So it helps you better engage the patient. So let me just model that for you in a role play with Kirk. Sound good? Okay. I'm going to pull up the scoring program. Hope it works. we're always fighting over who's going to deal with the blinding light. It's really unpleasant, so we're always avoiding it. You get over there.
It's not a blue light when you die, it's actually a CD projector. You're becoming one with it.
Yeah. Okay, so as you'll see on the Duke, the patient's just going to describe numbers or circle numbers that describe what applies to them. So I'm going to put those numbers, and this is based on age. How old are you going to be in the role play?
41.
And I knew you'd pick something like that. And then this is the drop down for gender. And then you're just entering in this row 17 single digit numbers. They're either a 0 or a 1 or a 2. So, and then you just push her down there. So we'll just start it. Somebody can time it. Okay, we're just going to ask you a few questions, and the first thing I'll do is I'm going to read some statements, and I want you to tell me, yes, describes me, no, doesn't describe me, or in the middle, somewhat. Okay, I like who I am, yes, no, in the middle.
In the middle.
Okay, and I am not an easy person to get along with, yes, no, in the middle.
Yes.
Okay. I am basically a healthy person.
No.
Okay.
My back's killing me.
Okay. I give up too easily.
No.
Okay. I have difficulty concentrating. Yes, no, in the middle.
Sometimes.
I am happy with my family.
Yes.
I'm comfortable being around people.
No.
Okay, now I'm going to ask you some questions about today and the extent to which you would have any physical trouble or difficulty. And I'd like you to tell me none, some, or a lot. To what extent would you have physical trouble or difficulty walking up a flight of stairs? None, some, a lot.
No, I couldn't do that.
A lot. Okay. How about running the length of a football field? Okay. Yeah. That's been a while back. Yeah. All right. During the past week, how much trouble have you had with sleeping? Again, none, some, or a lot?
A lot.
Okay.
Pain is just killing me.
Okay. And how about with hurting or aching in any part of your body?
A lot.
Okay.
Back.
And with getting tired easily?
Some.
Okay. Feeling depressed or sad?
No.
Okay.
Just in pain all the time.
Okay. Nervousness?
Well, you'd be nervous too if you had pain all the time.
A lot. Nervous or some? A lot. Okay. All right. And during the past week, how often did you socialize with other people, like talk or visit with friends or relatives?
No.
None?
None. Just been laid up.
Okay. Bad week. How about take part in social, religious, or recreational activities like meetings, church, movies, sports, parties? And during the past week, this is the past week, how often did you stay in your home, a nursing home or hospital because of sickness, injury, or other health problem?
A lot.
Okay, so more than 4 days.
Yeah.
Okay, so these scores I'm looking at
Patty, where
look.
does the more than 4 days come from?
It is 0, 1 to 4, or 5 to 7. So it's some, none, or a lot. A lot under that is more than 5, or yeah, more than 4. Okay. So so looking at these scores, it looks like, physical health is the main challenge, and it is impacting your mental and social health too. So I want to try and help you with that. If you come back to see me, and I think you will, I'll ask these questions again to see if we're making progress in terms of the plan we come up today. You know, is it helping you improve your quality of life?
Okay.
So that's how I would use it in an initial visit. In a follow-up visit, it's real quick. They already know what to expect. They may even fill it out on their own. And then it's like 20 seconds for me to enter the number. And then I can compare from the previous visit. And that's when patients, again, they get engaged because it's like, you know, you always feel good when your cholesterol goes down. At least I do. Or, you know, your weight goes down or your whatever goes up. So it engages patients. And so they may even sometimes say things like, well, how'd I do? Or, you know, they want to know. They want to know. They become invested in changing their behavior to improve their health-related quality of life. So, doable?
Question?
Sure.
On question number 16, if you ask a patient about that and they express that they have to do it all the time because their spouse makes them and they're clearly not happy to do that, how would you interpret that?
You know, I don't interpret it. I just go with whatever they say. Yeah, you know, it's just a self-report measure. You know, I would take that information into account, just like when he was telling me that he was in pain, and you know, I really learned a lot about him without stopping to explore it. And you know, I didn't explore any of the little things he put out there because it's not the point of this. It's not a you know, kind of an interview tool. We just want to get whatever it means to the patient, get a number, because they're their own control. When they come back, that's still true for them. So we'll be able to see that change. But I would take that information into account in terms of understanding where that person's at. You know, because there's not much joy in those social relationships, and that might affect, you know, the plan when we get there. Is, you know, what kinds of social things would that person like to do? So there's more joy in socializing. So that might show up in a mental health score rather than the social health score, because a more positive mood, less depression, but they're still socializing, just different. So I take it into account, but I don't ask any follow-up questions or interpret it. Good question. It's one of the things that the behavioral health consultants have to learn, that PCCs have to learn, is you have to kind of pick your areas to explore. You can't go down every rabbit hole, and patients are always putting them out there. You know, they're just talking, and we have to be responsible for choosing the ones that we go down, and they need to be the ones that are going to pack the most punch in terms of creating some behavior change, and that's going to work for the patient.
Back here. I'm sorry if I missed this, but how do you score this? How do you score their physical health, their mental health?
Oh, okay. Well, so, you know, when I put those numbers in, and let me just make this a little bigger. Figure out that program. Well, the scores, can you see them right there? See, those are the scores. So as soon as I put the number in, the physical health, mental health, social health, and general scores come up. So those are the ones that I recommend that you integrate into your electronic health records. So they range again from 0 to 100. They're already scored. I entered them while I was asking the questions. Like I say, depending on health literacy, many times patients can fill this out by themselves while the BHC is getting the rest of their chart up and started. So that, and asking a few other questions. So, yeah, so his physical health is 10. That's really low. And the mental health 40, social health 40, and general health 30. We got a lot of room for improvement. And these scores are so important. Like, for Kirk chose to play a chronic pain patient. Well, those are patients, many of those patients are being prescribed opiate medications. The PCCs are worried about that. When BHCs can put numbers like this into the chart, into the medical record, it gives them an opening for a conversation about, like, you know, you're asking for a refill on your medicines, but you're trending down on your Duke scores, your physical health, or, you know, we've not seen improvement since I increased last time. In fact, we saw a drop in social health. I'm really worried about that. So it really helps the whole team be more outcomes based in the care that they deliver. Just to mention, you know, there are all these other scores possible. So if you integrate the whole Duke into your electronic health record, there's other things. You can look at disability and other things like that. So down below are dysfunction scales. Higher is worse. You don't want more dysfunction. But the function scores, you want more function, so higher is better. All right. Any other questions, or we'll just go ahead and move back to the pediatric symptom checklist, because it's kind of the Duke for people under 18. So the pediatric symptom checklist is, I'm going forward. It works for kids 4 to 17. There's actually 2 different forms for the pediatric symptom checklist. One is for older kids, say 10 to 17, kids that can read and can score their own results or mark their own ratings. And then the one that's filled out by the parents. That age kind of really depends, again, on the health literacy of the child, the maturity of the child. I don't recommend doing 2 forms and then kind of comparing the parents and the child's, because that's not really what this is about. It's a screener, it's a ballpark figure. So it is interesting, though, very interesting to see how the 12-year-old and the parent work together on it, and it tells you a lot about their relationship, right? So 17 items. I don't think I have. Go ahead and yeah. 17 items. Takes about 2 or 3 minutes to complete. And you total it. I'll show you how to score it. But I'll model it, because I think if I model it, you're more likely to go home and experiment with it. And this would be awesome for PCCs and nurses to use in their visits too. Research suggests that if you use this, like just when kids come in because of any kind of problem, you're more likely to identify the need for behavioral health consultant service than if you just use it, for example, at Well Child. So you get better identification just at routine visits. So scoring is actually right there on the bottom of the page. You've got 3 subscales. There's the internalizing, attention, externalizing, and then you have the total score. And the cutoffs are right there. So to score this, you just, the columns never is 0, sometimes is 1, often is 2. So if you, for example, does your child fidget, is unable to sit still, if the parent marks often, that's a 2, and that you just check 2, and then you put a 2 under that column that says A, that's attention. So that loads on the attention subscale. Did that follow? So let's take the next one and see if you're tracking me. So act as if driven by a motor. Never. What's the score? 0. So again, it goes in that A column. And then you just add up all the A's down at the bottom. That's your attention scale score. All the I's, internalizing score, and externalizing score would be the E. And then you add those 3 together. Again, those 4 numbers, the 3 subscales, and the total number can be entered into your electronic health record, and certainly would work very well in terms of meaningful use. So I'll show you how I do this. One of the questions that I had during one of our breaks or discussions was, does it take longer to see a child and a parent than to just see an adult? And about 38% of my visits the whole time, 38 to 40% of my visits the whole time I was at Farm Workers were with folks under 18. So I really saw a lot of kids, and my visits on average were shorter with children than with adults. Well, how could that be? I've got 2 people in the room at least some of the time. It's kids don't tolerate, a lot of talking. So, I mean, you shorten it down, you get real focused, and you get the intervention, out there while the kid's playing, and you got the mother engaged, with younger children. With older children, like depressed adolescent girls, sometimes you have to kind of really make sure how you introduce the service and stick to your time. Other things that happen with children, sometimes you'll get like a child with ADHD and the mother is depressed. I recommend you create 2 visits, just one for the mother and one for the child. If the mother isn't a member of the clinic, then you can still code it as health and behavior code, patient seen with, or parent, family member seen without patient. And so the visit, the service is actually not lost in terms of your counting or tracking. So let me just show you how I do this. I need 1 volunteer. All right, now, okay. Okay, go ahead, come on up.
Oh, I gotta come up there?
Yeah. And bring a chair, or somebody bring a chair. Okay. And
Just
so,
come up and use mine.
so no, you have to, you have to be a part of it. Sit down, I'll tell you.
Or am I bringing the chair or am I not?
Yes, you are. Okay.
I'll use
Okay.
this one.
Yeah, use that one. So we just have to decide kind of what our role play is. I'm the behavioral health consultant, and one of you is a parent.
I'm a little older than you are? Yeah.
You're the parent. Would not. And then how old is your son?
Is it 13?
13. Okay.
Bill on wheels.
And, okay. And what is the problem that you've been referred for?
He was expelled from school for fighting.
Okay, good. All right. All right. Good.
Not
Have
that I've
some-
ever had to deal with that with my own.
Okay.
I've ever had to deal with that in my own life.
Okay, so we need a pencil. Okay, since he is 13, we're going to have him complete the pediatric symptom checklist, and I'm going to talk to the dad while he does it. And I'm also going to be trying to kind of tease out whether I should be seeing this 13-year-old by himself or with the parent, by virtue of kind of how that original 2 or 3 minutes is going. You know, if there's a lot of conflict, I may want to just ask Dad to wait for us. But I'm going to kind of honor the fact that Dad brought him in and is working and wants some help. But I'm going to keep him busy. Now, let's say it was a child that was 8. What I would do is I would give this to the parent, and then I would engage the child. and start talking to them, start my interview with them. So you just flip it, depending on the age. Okay? So, all right. Well, thank y'all for coming in, and I gave you the brochure and told you about the service. I'd like next to just kind of get a picture of the level of stress that you're feeling right now. I understand there's been some problems at school, and so this is something I'd like you to complete for yourself. And it's to what extent does this kind of describe you? Like fidgeting, unable to sit still, never, sometimes, often. So you just indicate, make an X in the mark that describes it. And I'll talk to Dad for a minute. Oh.
Yeah, do it honestly.
Okay, all right. Okay. So, all right, so is this your only child, or you have other children?
I couldn't imagine having another one.
Okay, so this is the one and only?
This is it.
And who's at home? Is your wife there too, or y'all married? Are you married, or?
We're married.
Okay.
She's at work, I'm at work, we leave them home alone.
Okay, and is this a new kind of problem, the problem with school? And getting along with other kids, or?
This is the first time he's been expelled for fighting.
Okay,
He struggled
okay,
with disagreements.
okay. And so he's 13 now, and just a little bit about your relationship with him, or the things that you two like to do together and do together on a regular basis, or
Oh, yeah.
what kind of
We go
things?
fishing.
Okay,
We like to go out to the lake, go fishing.
okay.
Every once in a while.
Every once in a while. It's hard to,
Yeah.
okay,
I used to go skateboarding with him, but
yeah.
hard on him.
It was hard on you. Yeah, it's hard. You know, sometimes our kids do develop different interests. And how about, does he get along okay with his mother?
She spoils him.
Okay. Okay. And what about, what does he do at home for fun? Does he watch a lot of TV or video games, or does he have friends over?
Yeah, not a lot of friends, mostly TV, video games.
Okay.
texting.
And texting. Okay. And his grades?
Not so good.
Like passing, C's, or?
Yeah, well, passing, C's. some
Okay.
D's.
Okay. And is that kind of average for him, or is grades going down, or about the same, or?
Seems to be just getting by most of the time,
Okay. For years?
for years.
Okay, he's always passed, and he's always gotten along well enough, but more problems this year, and then eventually a physical fight?
Correct. So I think he just does as little as he possibly can just to get by.
Okay,
And now it's escalating to fighting with friends.
okay. But he does his chores at home and helps out with the family, and,
Pretty much his mom does most of those.
okay. And so, not so many responsibilities at home, and that's because,
He doesn't want to do it.
and so his mother does it.
Yeah.
Okay. And how's it going over there? Wow, that was fast. Thank you. So, one of the things we need to decide right away is like if we're more likely to make progress, and we've got another 10 or 15 minutes to spend together. If it, you think it might be better if just the two of us talked, and then we'd fill you in at the end, or if there's more that you would like to tell me.
I think I should be involved in any care plan that we decide for him.
Okay.
You know, if you think he should be grounded, or if you think we should have some other disciplinary action, I should be part of that.
Absolutely, and I would agree 100%. So I tell you what, I'll let you go out to the waiting room, and I'll talk with him, see if we can put our heads together, come up with a plan to make things better, and then we'll fill you in on that plan.
Okay.
Okay, thanks. You can get your pen back. I'm very bad at taking pens. Nope, that's good. Okay, so I'm going to tell you, I'm going to score and tell you what his scores were. And you can kind of tell me what you think they might be. Okay, so. I love this because it's so fast. Oh. And what I always do when they give two answers is I just take the highest one. Okay, so the scores is just that fast. Internalizing is 2, 3, 4. So, he's hurting, so I'm tuned into the fact that, and of course he made comments about Dad wasn't paying much attention to him. Attention, no surprise, seemed like he was pretty tuned in and that attention wasn't part of the problem, so that's only a 2. Externalizing, 2, 4, 6, is 6, so it's not outrageously high. When we add them all together, we've got 12. So he's not above the cutoff. And many of the kids that we'll see in primary care are not like, they don't have, all the wheels falling off. And it's good to know that, This gives me kind of a measure. It gives me a direction in terms of, am I looking at more one thing than another, or is it like everything, a depressed kid with ADHD and oppositional defiant disorder, as opposed to maybe a 13-year-old that's a little depressed and probably had something happen at school that hurt his feelings a lot and got into a fight. So that's how I'm conceptualizing it as I move forward. So very useful when the patient comes back, I can give this again and see if we're moving in the right direction, and it's very fast. Make sense?
Just a quick question.
Sure.
This says caregiver completed, but you gave the same form to the teenager as the caregiver completed. You wouldn't have a separate one for an adolescent completed one.
You could. The other thing I haven't seen anybody do, but I think would make sense, is you could make a version of this that says, does your child, or do you? And then if you're giving it to a teenager, you just mark out, does your child, and say, do you? And if you're giving it to a mother, mark out the other. So you don't have to shuffle as many papers. I think there's maybe one item that's slightly different, but they're essentially the same, just like the PHQ-9 for adolescents and the PHQ-9 for adults. I mean, it's essentially the same. It's probably not worth the shuffling papers around. Okay, so could you use them? Would you know what they meant if you saw them in a chart note by BHC? And that's the point. Okay. And now, speaking of charting, let's move on to charting, a chart note. So we are still in that tab 7 in the white folder. And in this case, what we're going to have to do is the person with the white folder or the black one, the toolkit, is going to have to share with the other people at the table to look at an example chart note from a BHC, because this is kind of the way we recommend this done. This is the way they're going to be trained to do it this week, and we want to make sure that the nurses and PCCs know kind of what to look for in the chart note, because it all works together. Because when the patient comes back, what does the PCC need for a medical visit? What does the PCC need to be able to do? Support the interventions started by the behavioral health consultant. You need to be able to quickly look at that chart note and say something to the patient that encourages them. That's what we call continuity, okay? Same thing, if you're a nurse, you're on the phone, you're talking to a patient, last visit was with a behavioral health consultant, you want to be able to look at that note and say, oh, hey, have you been working on noticing your pain level? And how's that going for you? How about engaging in pleasurable activities? Have you done anything today, or what are some of the things you've done in the past week? Okay, so in that way we create continuity. So there's an example chart note that why don't you guys read over real quick, and then we'll talk about the most important part for PCP, PCCs, and nurses. Did you all find it? It's in 7, section 7. Basically, it's pretty brief. It's kind of spread out on 2 pages just to make it look good. But if you took out all the fluff, it would be 1 page at most. So it's very focused on what the problem is. There is just a brief snapshot of the patient's kind of life situation. The things that are really important for PCPs and RNs to look at is what were the interventions used. If you'll take a minute to look at that, over time, you're going to learn some of these brief interventions. You're going to learn the version that's 2 minutes rather than the BHC version, which is 5 or 10 minutes. But if you'll look at them, you may know enough about them that you can even kind of do a little skill instruction in your brief medical visit. Next are the recommendations to the patient. I train the BHCs to write these down using the same language that they used with the patient. So you don't have to do any translating if you're the RN on the phone or the CCO person. You don't have to do any translating. You just say it the way it's written, and that's the way it was said to the patient. Maximum continuity. And then recommendations to the PCP or PCC. Many times they're pretty standard, like support the behavioral or the recommendations to the patient. But other times there may be some very specific information about patient preferences or barriers to this or that the PCM will need to kind of call out and look at. So if you only wanted to look at 2 sections prior to your follow-up visit or during your phone call to a patient that's been seen, look at the recommendations to the patient and the recommendations to the PCC. Okay?
So this brings up some potential dilemmas. In our office, our policy is that if we have a patient who's on chronic pain medicines, we don't allow them to use marijuana or other illicit drugs. And we want to foster real communication, honesty with our providers. Certainly this chart note would be a real red flag. Somebody coming in with chronic pain who admits that he occasionally uses pot. That I want to foster a good relationship with the patient, but I also don't want to endorse destructive behaviors.
Right. Well, honestly, it varies from state to state and PCC to PCC as to where they stand on marijuana. So I think it has to be, clinic, or it has to be a part of probably the relationship between the patient and the team. And it may be a clinic-wide policy. Some clinics, some providers turn their head the other way and some don't. And they're very clear on it and they test for it. And so I think patients just need to know. And either they're tested and found to be using it, or they tell you, or whatever, and there's a consequence. And you have to kind of work through that as a team.
I don't want to get off point with this, but in our pain contract that I was talking about, the standard one, the PCC identifies the drugs that the client is not to use. because of this very issue. And of course, our state just passed this legalization initiative, you know, so it's bringing all that up. So actually, you can build a form where people circle, you know, alcohol, you know, marijuana, heroin. I mean, you know, there's not an unlimited number. So you can actually customize this.
Yeah, it depends on what your paint agreement says. You know, you just follow it. Okay, these are the health and behavior codes, and the Medicare carriers coverage rates or reimbursement rates. It kind of varies from state to state, but that's kind of just something that I said I would put in terms of reimbursement.
I have a question that was asked earlier, and I want to relate it both to the health and behavior codes as well as this program chart note.
Okay,
I
good.
work in a private multi-specialty medical group, and in this note, I don't see any kind of formal diagnosis, ICD-9 code. I won't even use DSM-4, so there's no ICD-9. How will billing, what format would you use for billing, or what adaptations would our agency have to make in order to have this covered through insurance? Should we be coding? Is a coder going to do it?
There is specific, no, you should be coding, but it wouldn't be on your chart note. It would be on your encounter form, or, you know, it's just not on this chart note, but there would be a procedural code and a diagnostic code associated with your visit.
Who would be making the diagnostic code?
You would.
And it could be a pain code rather than a DSM-4 code.
Oh, for sure.
Okay.
Yeah, and many times there's a code in DSM, ICD, and yeah, both. And so, yep, and usually built into the electronic medical record. If you're using health and behavior codes, you're going to be using medical problems. So in this case, you would be using health and behavior code. You would use the initial 15 minutes 96150 and the intervention 96152.
I'm more thinking about the diagnostic code, not the procedure code.
Yep,
Okay.
and the diagnostic code would be, you know, chronic pain, or whatever it was, back pain, low back pain. Many times that's already entered into the medical record by the referring PCC, so you just accept that diagnosis and you just pick it out of the problem list. It's real fast, just like that. You move forward. Yep. Good point. Okay, so then one thing, I got to turn it over to Kirk for a second to say something about the program evaluation matrix, which is something you can work on at home. But I did want to mention the referral barriers questionnaire. So today has been a big day. We've gone through a lot of information about a particular model that brings behavioral health into primary care. We've talked about your readiness to move towards that model. We've looked at your individual competencies in terms of practicing in a way that's consistent with that model. And I want to mention that the referral barriers questionnaire is another way for you to kind of say, where are we? So behavioral health consultants, when you go back to your clinic, use the referral barriers questionnaire with your PCCs and nurses to help you identify what's getting in the way. So if your referral rates are variable or consistently low, maybe you're just getting this started, this is an excellent tool for identifying things that can be quite subtle in terms of interfering with the PCC or RN's choice to use your service. And then you can address them systematically. We will cover this in training over the next 4 days, and so you'll be prepared to use that. So our recommended program evaluation matrix covers 5 areas.
Okay. 1 minute per area. Okay. Hey, 2. How many of you are kind of on information overload at this point? Okay. This is kind of what happens when you go through a project too. I've noticed that you kind of get to the end, you got it all figured out, and then some geek stands up like me and says, well, how are we going to evaluate this? And everybody, the air just kind of goes out of the room. And so what we really encourage is don't wait until you're way downstream and then start trying to figure out how are we going to evaluate this, but kind of make that part of the upfront process so that you have some energy for it and it isn't sort of like the last thing that got done, which means it won't get done. That's been my experience. And I'm not going to bore you with all of the different things that you can measure. I'm going to give you a few sort of practical pointers. One is try to mine existing data. You know what I mean by mining existing data? So like if you're keeping a UDS data set, if you're an FQHC, there's quite a bit of information in that data set that you could actually directly apply to characterize your program. A lot of EMRs are going to have these meaningful use reports coming out, and without much tweaking or modifying, you're going to be able to extract data out of there. One of the things I've noticed over the years is that if you have to add new processes to measure something, that's adding new expense. Somebody has to do it on top of all the other things they're already doing, and your chances of that not getting done increase. So the first thing I will encourage people to do is look at what you're already collecting and see if you can't tweak it slightly so it might fit some of these categories. Yeah. So, one is health status. You could use formal measures if you are interested. And, the Duke program that we showed you is an Excel-based program, so you can actually feed it into an Excel database, all these scores, and then they're automatically vectored into your health record aggregate database. It isn't really that hard to do. But there might be other types of ways that you measure outcomes, like A1C, changes in A1Cs, changes in PHQ-9s that might be required of your meaningful use criteria already. And so some of this is adding to that.
Also, just supporting PCCs in their efforts to focus specifically on primary care delivery. So you could look at things like preventive service delivery rates among the patients for services like immunizations and pap smears. Does this help? This is satisfaction with care. There's a variety of different surveys we can share with you. Access to behavioral health services. There are a variety of strategies for you to measure access. And you can read through these and kind of think through, as Kirk was suggesting, what data sets are already available to us. To get at this data, what we have to do. And then detection and fidelity to the model. Detection, all of these, everything in the matrix ties to the program goals. And there's different measurement strategies, and you can choose them based upon the resources within your practice setting. Fidelity is very important because if you're not practicing with fidelity, you may not be able to attain the outcomes associated with the model. So you do need to measure fidelity. So you need to be thinking about like the average number of follow-ups, days to next appointment, that sort of thing. So they're all listed out there for you, and we're kind of coming to an end. I want to give people a chance to ask questions and then just tell you a little bit about the future trainings coming up. Well, I'll tell you that first. We have a plan of going into identifying 2 to 4 practices as best practice sites that could be kind of centers of excellence where other Oregonian PCCs and operations folks and behavioral health providers could go to learn more about a well-performing primary care behavioral health service. So if you're interested in this, please let us know. In the training over the next 4 days, behavioral health consultants that are interested in this, I'll be sure to give them a chance to kind of act in some leadership roles and try out some co-teaching to kind of see how much do I like this. So it's very important as we transform healthcare and mental health care, and we create a new role for us as behavior health providers, that we look for people that are going to excel at this. And so mentors or experts are typically people that excel on the core competency tools, so they're really getting high ratings in all areas. And then they have the additional skill of being able to teach. And if they don't have that, because many of us didn't get a degree in education, that's something too that can be taught. Typically, the way that we have trained people to be mentors is to co-train with them. So we will find a new person. That's what's involved in the spread and sustain best practice kind of training. The first is identifying a new behavioral health provider, brand new, who reads the manual, passes a content quiz, like all of the behavioral health providers will do tomorrow, on the manual after studying it more, and then to model and coach the new person with an expert coaching you on both how to teach and refining any skills that you need in terms of delivery of services and working as a team member and influencing the system, creating pathways. So the other thing involved in spread and sustain trainings coming up in January and February will be trainings for all of the PCCs, the nursing assistants, front desk. We trained everybody in the clinic on this and reduced a lot of variation and create a lot of power in the clinic in terms of really making this rock. So that's coming up. Questions? You guys tired? Yeah. Okay, well, I'll just say I really encourage you to study your manual. And am I right that everybody gets a thumb drive? Yeah. So you guys have got it. We just didn't want to burn a bunch of paper when it's probably a lot easier to use your manual and the other items in your toolkit